Good afternoon, everyone. Thanks for joining. We have our participants trickling in. Thank you all for being here. The second issue hub hosted by the American Cancer Society National Consortium for Cancer Screening and Care. This one is focusing specifically on strengthening public health and healthcare systems to advance cancer screening and care. And we are so excited for you all to be here. Just to let you know, a little bit of level setting, making sure you're at the right meeting. Welcome and purpose of today's call. What we're really going to try to do here today is explore the vulnerabilities within our nation's public health and healthcare systems that contributed to the decrease in cancer screening and care during the pandemic. We're going to take some time considering the potential action steps that can help us build resilience in our public health and healthcare systems going forward. And we're also going to look at some case examples and really talk to some folks that are running programs, running interventions on the ground, and see what we can learn from them as well. So as we look at the learning objectives, what we're really hoping for you all to walk away with today is identifying a few weaknesses in the US healthcare system, the public health system, that likely worsened outcomes in cancer screening and care during the pandemic. We want you to dialogue around sensible solutions to strengthening our healthcare systems to be better prepared and equipped to address future disruptions. And then we also are going to learn a little bit how systems have successfully navigated cancer screening and care during the pandemic and improved outcomes. So as we look at today's agenda, I'm going to run through a couple of quick introductions, general housekeeping, some technology orientation for us. We'll also be doing just a brief level setting of where you're at, who the American Cancer Society National Consortium is, kind of what this issue hub concept is, just to let you know where we're at in this process of thinking about some of these things for our country and the pandemic world. And then we'll have some really great discussion areas, and we'll talk about the great panelists that we have here with us today to really kind of enlighten us and give us their insights and perspective. And then we'll close out the meeting. So the panelists, on the left there is going to be our first panel, some really great representation from national organizations, the National Comprehensive Cancer Network, Association for Healthcare Research Quality, the National Association of Community Health Centers, Association for State and Territorial Health Officials, and then the American Cancer Society. And on the right, we have some examples from Washington and Nevada that we'll be having some really great discussion with about those case examples. We'll do more introductions about these folks right before their panel, but we just wanted to kind of give you a little taste of the list so far. And then I also just want to recognize we have a lot of supporting cast that you may hear or may see in the chat through the session. We have Megan Burns, who will be kind of running our Slido, Nikki Stevens, who's our Zoom producer extraordinaire, Sarah Schaefer, who's done a lot of work as being kind of the content director for this, Ryan Swayson, who's going to be doing some of the hard facilitation work for us during this call today, and Kirsten Orlander, who is going to help us make sure that we're synthesizing this information and able to deliver this and package it after we have the session today. Just a couple of virtual housekeeping tips. The event is being recorded. The replay and slides will be made available within a few days. And we will be sending out notifications to you all via email. All the participants will be muted today. The participant polling opportunities and general discussion will be used in Slido. So we won't be using the Zoom chat. We'll be hosting all of our discussion in Slido. We'll talk just a second about how we get to Slido and kind of why the reason that we're doing it there. We will offer the use of the Zoom question and answer box, but we'll only really answering technical questions there. At the end, we'll have an evaluation forum. We ask and always ask that you do those for us so that we can make sure that we improve our sessions. And then there will be a brief summary sheet of kind of what we discussed today and kind of the synthesized information that we have put together. I'm also really excited to let you know about the launch of the American Cancer Society National Consortium for Cancer Screening and Care website. So it's consortium.acs4ccc.org. That should be dropped into the chat now in case you want to click over there and take a look. We've gotten a lot of interest in the National Consortium, kind of what's going on, where we're at in the process, things that are being created. So we've put this website together to kind of help you keep informed, help you know when webcasts, when issue hubs are coming, when different reports and guides are coming out from the National Consortium. So that'll be the one-stop shop to go to make sure that you're up to date with all of our latest information. So like I said, we'll be using Slido today to really handle our polls, to handle our instant reactions, to handle all the comments that you all are having. The reason for that is we really want to have two dialogues going on today. We want to have the dialogue of our panelists. We're going to be listening to them, hearing from them, but we also want to be crowdsourcing a dialogue, hearing what your solutions here, hearing what your feedback is, hearing what your comments are. So if you're comfortable having two screens, having a Slido conversation going on, maybe working on your phone as well as watching the webcast, we invite you to go over to Slido to be a part of that. If you don't and you just want to focus in on the Zoom call, that's fine too. It really is an optional thing, but we would love to hear kind of from you, people that are working within the states, within the communities, on the ground, your perspectives and what you're hearing today. So to do that and participate, you go to slido.com or Slido, the link there that's on the page. I think that should be dropped in the chat as well. You can enter meeting code SEPTHUB, or if you use the link in the Zoom chat, that'll get you all set up pretty much right away. You can also use your computer or your mobile device in case you don't have two screens. And this is what it looks like if you go to slido.com, you can enter the code. That's where you would enter in the SEPTHUB for this particular event. That'll open up the page for you. Whenever you get in there, today we'll be launching some different polls. Right now, there should be a practice poll available for you. Please go ahead and fill out the poll. It's just kind of a fun response, a little bit just to get you used to the technology and get you started with the general process of what you'll be looking at. So polling will be one option today. The other thing is that we'll have is this ideas tab. This is really our discussion, our dialogue that we would like for you all to be having while you're watching and commenting and figuring out. There'll be some prompts, some things that we hope that you all can respond to. If one of your colleagues says something that you really, really like, there's an opportunity for you to use kind of an upvote and like that particular post. If there's something that a colleague has said and you want to respond to it, there should be a reply that you can reply. And we'll be offering some different prompts as the discussion continues throughout the call. So the other thing that I wanted to just kind of level set on just a bit is the National Consortium for Cancer Screening and Care. And give you an idea of just kind of where you're at and where you're joining in the process, why we're having the discussion that we're actually having today, and why it's important to some next steps that we hope to do with the American Cancer Society and our partners that are really engaged with this national consortium we put together. So the American Cancer Society launched an enterprise-wide initiative in response to the pandemic, making sure that we were responding quickly, we were responding really comprehensively in a lot of different areas, and trying to help get back to cancer screening, but also follow-up care, and looking at a number of issues. And so as you can see here, we have 6 building blocks for this initiative. The one that you're joining today is the National Consortium. That's a group that we've put together that is really national leaders, researchers, clinicians, thinking about what we need to do to identify and really make some recommendations. And I'll get more into what the National Consortium in just a second. We also have other building blocks for state coalition leadership. We have other building blocks for health systems and screening intervention work. We have a public awareness campaign that's launched from the American Cancer Society. Our researchers are trying to understand the impact of the COVID pandemic. And then we also have our policy arm, the American Cancer Society Cancer Action Network, working on a policy agenda and a policy agenda that responds to the pandemic as well. The enterprise-wide initiative has a number of funders. You can see those listed on the left. And then I also want to recognize that the National Consortium members that have just been a part of these conversations and giving us their time, their volunteer time this year to really walk through this process with us. Here are some of those members listed out. Again, I'll be sharing these slides, sharing these recordings, so you can have access to this member list. It's also listed on the new launched website. So when we're talking about the National Consortium really convenes organizations, scientific advisors to accelerate, strengthen, and mobilize around bold but sensible cancer screening and care activities. The way that we're doing this is through phased work with 3 goal statements. Each goal statement has a phase of work. So the first goal statement is accelerate our responses to longstanding and emerging barriers to cancer screening and care. Then we're going to strengthen our preparedness, infrastructure, and partnerships to minimize disruptions and address inequities. And then we're mobilizing around sustained, coordinated commitments to promote cancer screening and care as a public health priority and improve the long-term effectiveness of screening programs. Just so you know where we're at in the process, kind of the calendar of events, everything in gray there is that first phase, that accelerate phase. We have put together some recommendations. That phase is fairly close to being wrapped up, and we've started into our second phase, which is kind of this blue purplish color. So we've held a data webcast. We're now today on this strengthening issue hub, and later we'll be coming together on a strengthening summit where we're really going to decide what are some more recommendations that we need to be putting forth nationally that can help us improve cancer screening, cancer care. We have some other things that we hope to do, a health equity issue hub, maybe a second data webcast, and some other summits that we have planned for the rest of the year, but really getting us to what these final recommendations may look like, and how we as a cancer community, a cancer fighting community, can mobilize around these recommendations, both the stakeholders of the National Consortium, but broader stakeholders across the country as well. Just to give you a little taste of what these recommendations look like. So the process that undergoes, we have these issue hub conversations. We get a lot of information in from you all through this Slido dialogue. We get a lot of information from the panelists that are joining us today. We take those into a summit, and then we develop the recommendations that kind of look like this. And this is the recommendation list that is currently under review by our National Consortium members. So these are very much in draft form, but we did want to share that, we're focusing on some particular areas from this first phase: national partnerships, coordinated messaging, proven programs, quality measures, and pandemic-related innovations. I won't go into the specifics of each of the recommendations quite right now, just to save us some time. But I do want to just keep this up for you all just to see what the recommendations look like and how they really attach to the theme and the conversations and the dialogues that we build through each phase of work. As we're framing up today's issue hub, and as we're thinking about the strengthening piece, the accelerate phase, we were able to really think about some places where we could move quickly, where there were the hurdles may be smaller to overcome. We don't have quite as many challenges, but we also want to explore. So today we're going to be into the strengthening phase. We're actually going to be exploring more vulnerabilities within our nation's public health and healthcare system, and offering the solutions to build resilience within our healthcare systems. Today we might get into some conversations where the recommendations that we need to come up with, the solutions that we need to offer, may have bigger hurdles, bigger challenges for us to overcome, more substantial barriers in the way. The first panel will provide a national perspective with generally broader overarching solutions, while the second panel, the second panel is going to really get into some case studies, reflecting a little bit on some of those national problems from the first panel, but they're really going to be speaking about their interventions, their programs, what they're seeing as accomplishments, and what they're seeing as challenges that they're still trying to overcome. We are about to launch a poll for you all to kind of take part in. It's not launched yet, but we should be launching it here when I transition to Ryan. And I want to just say that we're going to ask you a question. You're going to go through the responses. We have some problem statements that we're hoping that you can kind of help us pre-select. These will help us in the discussions going forward. You'll notice that not everything is listed there. It's not a comprehensive list. These are predetermined, and they're purposefully narrowed for the needs of this goal statement and for the discussion today and the panelists that we brought together. But feel free to continue elaborating on the conversation, your reactions to the poll in the Slido dialogue as well. With that said, I'm going to pass to Ryan very quickly to kind of explain our fishbowl format and really get started with the process today.
Caleb, thanks so much. I think the poll already popped up, but let me just explain what we're doing. If you've been with us before, you've seen this, this format with the panelists. We'll have a discussion lead. We'll have a panel of 3 or 4 folks, and we'll have a conversation going that everybody, all of our participants can listen to. And as Caleb suggested, also commentary in the Slido if you want to engage in the commentary in the Slido, or you're more than invited to just listen to the discussion lead and the panelists. So in a moment, I'm going to turn this over to Dr. Laura Makaroff to lead our first panel. But before we do, just know that Laura will be asking the panelists questions and then doing a very brief summary of the panelists' conversation before we turn to our second panel. So we see the poll already up on the screen. So again, if you are going into the Slido, you can answer the poll questions. Let's just give it another moment here, but you can pick 2 responses from the list below. What are the most significant vulnerabilities in the U.S. healthcare and public health system that likely contributed to worsened outcomes in cancer screening and care during the pandemic? So it looks like most of our folks have had a chance to respond. Megan, Nikki, is that correct? Oh, no, it looks like we got 71. I'm going to let this go for another minute. Laura, when we get you on screen here, I think we'll just ask for any commentary you have. Let's give it just another minute while people are still filling out the poll, but we'll get some commentary from what you're seeing in the results. And then please feel free to introduce your panelists. So we're still at 80, we're at 84 people. I know we have a couple hundred here, so just give it 20 more seconds.
20 seconds of silence is a long time, but
why don't you comment here, and then we'll move over to your panel.
Okay, that sounds great. Thanks so much, Ryan, and I'm so happy to be here today, and thanks for the intro, Caleb. So by way of intro, just to make sure everyone knows who I am, I'm Laura McGrath. I'm a family physician, and I serve as Senior Vice President of Prevention and Early Detection at the American Cancer Society. We've been engaged in this work about addressing COVID's impact on cancer screening and care throughout this year. I'm really excited to be here today to have this discussion. So this, my thoughts on this poll, it's really interesting to me. I am surprised to see that the dependency on fee-for-service versus value-based didn't get as many votes. I thought that might get some more votes, and I think that that's an important piece. But I'm curious to see kind of what the panelists think about that. And then I think the other thing that maybe isn't so surprising, but I'm glad to see all of the votes in the poll around the culture of healthcare that deprioritizes population health and preventive care, and how that's eroding public support, understanding, and confidence, specifically in the cancer screening, early detection, and prevention space. So I think that is maybe not surprising, but I'm happy to see that, and I'm interested in our discussion that we're about to dive into. Should I go ahead and move on to introduce the panelists, Ryan? I think that's
so let's have all the panelists come off their video, and Laura will start making introductions.
Great. So a big welcome to our distinguished panel here. I'm going to do brief introductions and of our panelists here. So first we have, I'm looking at my notes to make sure I get everyone's title right. So first we have Dr. Crystal Denlinger, who is a medical oncologist and Chief Scientific Officer of the National Comprehensive Cancer Network. Welcome, and thanks so much for joining us today. Next, we have Dr. David Myers, who's a family physician and acting director of the Association for Healthcare Research and Quality. Welcome, Dr. Myers. We're happy to have you with us as well. And next we have Dr. Cheryl Modica, who is the director of the Quality Center at the National Association of Community Health Centers. Welcome, Cheryl. We're happy to have you with us also. And last but certainly not least is Dr. Marcus Plesha, primary care physician and chief medical officer at the Association of State and Territorial Health Officials. So we have a really nice interdisciplinary panel reflecting specialty care in the oncology space, reflecting quality and quality improvement around, especially in the health center space with Dr. Modica, the primary care policy lens and the federal government with Dr. Myers, and then the public health space and how our public health infrastructure is really being challenged in deeper ways for such an extended time through this pandemic with Dr. Plesha. So I'm really happy to be with you all today. So we're going to spend some time looking at each of these topics and having some discussion. So first, let's start with the one that got the most responses in the poll around the culture of healthcare that deprioritizes population health and preventive care. What is your reaction to that, and what would you say could be and should be part of our solution making on that topic? I think David's off mute, so let me go with you, David, to start, and then we'll open it up to the rest of the panelists.
Oh, thank you, Laura, and thank you to ACS and the consortium for inviting me here. It's very exciting. I'll remember to stay on mute longer next time. One thing that strikes me about the prioritization here, I think it's actually a signal of what our larger health system does. Sometimes I think we have a rescue care system. Prevention never has gotten the focus of the healthcare system. And I think that's where primary care and public health systems often overlap and are both the underfunded and under-resourced group. And an example of this kind of rescue thinking that I think we saw happen in COVID-19 is that care managers in primary care and public health and in healthcare systems that helped people manage chronic conditions, got people their screenings, their flu shots, their mammograms, were the first people reassigned when health systems experienced the surge. And while that made sense in the immediate moment, what it meant was the people who could have helped us emerge from the pandemic with people still having their regular care, still having access to care, having their chronic care, cancer care needs met, their screening needs met, were the ones not there, and the system fell apart. And this is going to be, I hope it'll be our 5th wave, that we're done with our waves of COVID, but the recovery is going to be much, much longer because we took the people who care about prevention and screening and chronic care management out of the system right when we needed them to be there.
Yeah, really, really important point. And I think we see the impact so greatly, including on the workforce piece, which you're speaking to, and how we just, sort of first cut, like redistribute that part of the workforce, but then also really sort of had to make some decisions broadly about telling people not to go in for elective care or preventive care at the very beginning. But I think we're still seeing some of that ripple effect even this far out. Other thoughts, others, just chime in. Dr. Denlinger, Dr. Klesha, Dr. Modica, what are your thoughts on this issue of how we haven't yet gotten to a place in this country to prioritize preventive care?
Well, I'll chime in. This is a long-standing problem, and I think David just spoke to it really well. But I do see some reasons for optimism as well. I think the thing that's come to our rescue in the COVID pandemic is a vaccine. And a vaccine is a very basic preventative care type of intervention. And my hope is that maybe this will begin to shift people's attention and people's thoughts a little bit more to the fact that there are things that we can do and we have this astounding example of something that really is the only way out. And I think as far as the field of cancer prevention and control, we need to find ways to kind of link to that and segue to that. And as we start to come out of the pandemic, really sort of try to build on some of the lessons learned and hopefully people's realization that, sometimes preventive approaches are the most powerful of all.
Yeah, I really like that point. And it is maybe our opportunity, our silver lining is this, the COVID vaccine is really highlighting and showing people that prevention really does make a big difference. How, Dr. Denlinger, I'm interested in your thoughts on this. How would you, Marcus's thoughts on how we take those lessons learned or help the public start to think about cancer prevention similarly as we think about COVID prevention or ways to help the public think about prevention differently? What are your thoughts on that?
Yeah, so I think this is a really important point that we have not, as a healthcare community or as a general population, thought about prevention as a primary means to address cancer care. It's usually that someone gets diagnosed with cancer and then we address the diagnosis as opposed to addressing the diagnosis from the preventative piece. And this is true both for a primary diagnosis and even in our cancer survivors, where maybe the number of survivors receiving screening for other cancers is not as high as we would like it to be. And that's even amongst oncologists and oncology communities where we know the benefits of cancer screening. So it doesn't surprise me that this is the #1 answer, and I think it is important. I think one of the things that I would like to see move forward is that we take this moment to be a teachable moment where we can talk to the public not only about the benefits of primary prevention and the use of screening and preventative measures, not just for COVID, but potentially for cancer. We know that screening saves lives for a variety of cancers. We know that behavioral health measures and health behavior adjustment, including engagement and things like physical activity, can be helpful in lowering the development of certain cancers. And so using this moment where public health intervention and or preventative actions could result in avoiding a negative outcome long-term could be useful not only in the COVID world, but also to think about cancer prevention and early diagnosis.
Yeah.
And maybe just to build on that comment, again, I'm from the National Association of Community Health Centers. And one of the things that we're doing at the association, and it's, as Dr. Meyer said, early on, many of the staff, like care managers, community health workers, navigators, et cetera, were redeployed in ways. And so we're now kind of circling back and redeploying them and using the opportunity to get at the heart of what is it that patients are in this era of COVID, what are they concerned about? And so they are more concerned because they hear in the news, they hear in the media, et cetera, about the additional risks if you have hypertension or you have diabetes. And so through some of our CDC efforts, and I know I saw Dr. Richardson's on the line, and so through our CDC project, one of the ways we've been very successful in cancer screening is to approach patients through their chronic conditions. And so we've deployed, we actually had a national pilot where we put together what we call patient care kits or self-care tools. And we used folks like the navigators, like community health workers, care managers, et cetera. And we delivered those to patients in their homes and then taught them how to do things like self-measured blood pressure, home A1Cs, scale and weight, and all those kinds of other conditions or other things they may be focused on. And then that's the entree. And we said, oh, by the way, and in order to be eligible for this kit, they had to be over the age of 50 in our case. So it was, and we would look and see if they had had any colorectal cancer screening in appropriate timeframes. And if they hadn't, then we had a test ready for them. And so we were actually very successful, and we're writing up those results now, but we found a number of reactives or positives that otherwise would not have been diagnosed and have since gone on to colonoscopies. But again, the approach was to use that kind of opportunity where you're both re-engaging staff that I think was early on redeployed, and then also approaching patients through other issues that matter to them right now and that they are concerned about.
Perhaps that may be one of the important keys too, is that comorbidities matter, and that a diagnosis of high blood pressure or diabetes actually is more than just an elevated number when you go to your doctor. And that may be a way to sort of bring in the collective knowledge that these comorbid conditions in and of themselves may not necessarily be a problem per se, but it's sort of a gateway to potential other complications. And so if you're aware of the downstream implications of a diagnosis of diabetes or a diagnosis of high blood pressure as it pertains to a public health crisis, that now puts it front of mind, and a patient with that diagnosis might think, well, what else can I do to minimize my risk? And that's where the question, or that's where the introduction of cancer screening and maybe even other disease screenings, other cardiovascular disease screenings, where that preventative screening piece comes in. That's your introduction right there. This is your diagnosis. This is how it impacts the COVID pandemic. Let's talk about how it could impact something else.
Yeah, that's a really good point. I mean, I think this concept that being healthy matters has been driven home by, looking at who suffered the most in the pandemic.
Yeah, I think so too. And the idea of sort of packaging or meeting people where they are in their life space and their space with other comorbidities, I think it's so powerful. And I can, draw back from my early residency days, and I just have voices of attendings who were, would always say like that the patients in the office are on the screen, and nowadays with telehealth, like that is our opportunity, especially in the primary care space, to just review where we are with cancer screening and other preventive services. It's really key. The action steps around how we build the primary care workforce to do that, and the community health center workforce, I'll add in to include primary care and others. In an overburdened system that is being crushed by all kinds of demands, I think is something that I want to pivot to here in a second. But let me let Ryan chime in on the Slido conversation, then we'll get back to like some ideas from the panelists on how do we help our overburdened system do this and really package preventive care together and meet people at home where they need to be, or in the office, or over telehealth, or all those different things. So Ryan, let me turn it to you on the Slido conversation.
Yeah, thanks, Laura. And you jumped on the first thing I was going to say. You might want to pivot, and I'll chime in one more time just to keep us on time. But I'll just reminding folks that we have the Slido open, and Megan, feel free to put that link back in the Slido. We're starting to get a robust conversation there, and so I'll invite everybody to continue having that dialogue. But Laura, I'll just turn it back to you.
Okay, that's great. Thanks, Ryan. This is great. This is like truly a test of all of our multitasking that we're getting so maybe good at. I'm not sure that's possible from what the research says, right? But clearly, feel free to engage in the conversation in the Slido, and then we'll continue this conversation too. So I'm really interested in this concept of how we package primary care. I guess also preventive care is what I meant to say. And in the right ways. I think at home stool testing for colorectal cancer screening is such a key part to this, but it could include other things like a phone number to call to get your mammogram scheduled, or the web link to get your schedule done. You know, it doesn't have to only stop at home stool testing, but the idea of like, how do we support the system to do that better and use the team and do that. So what are your thoughts on that as panelists? Just chime in, whoever has an idea first.
I'll jump in.
Great.
And this actually gets Laura to the, I was a little surprised also that the fee-for-service versus value-based healthcare didn't rise a bit, because I think some of the reasons why it's so hard for systems to think about prevention and packaging things and meeting patients where they are, all things that we've brought up as a panel today, is that they're not incentivized to do this. One of the things I'd love to see are, as we move forward, and I'm sorry I missed the consortium's data call early, data hub call earlier, are we going to be able to see that more integrated systems, the VAs, the Kaisers, were able to shift and pivot to bring care home, as you said, or make sure that people didn't fall off the radar? Were they more successful at doing that? And were primary care offices that were independent and didn't have the ability to do these innovative kind of shifts? And even going further, I think there's an issue about how our public health system and our primary healthcare system have so much trouble working together. They don't speak the same language, but they're also, they don't have receptor sites because of the incentives, especially on the medical side of the healthcare system, to work with public health. And some of these ideas of packaging require that we're all aligned in a patient-centered system. And I'd love that to be an issue. I like that it's in the strengthening phase, because that's a bigger barrier, but could have such rewards.
Yeah, good point. Cheryl or Crystal, thoughts on this from both the oncology care team space as well as the community health center care team space, on where we're seeing successes, where we need to be sure to strengthen and add to see more successes?
Maybe I'll comment that one of the things we saw early in the pandemic, not only I think we saw it in health centers, or I'll speak for health centers, but we saw it in other healthcare arenas, was that, again, the redeployment. So our sort of vision, or our historical view of the care team shifted during the early days out of necessity. And at the same time, there were some of the concerns, like Dr. Meyer raised, where people that may not have been the best redeployment. In other cases, there were some really positive redeployments, and some really sort of allowing people to focus or work at the top of their licensure, allowing folks to do expanded job roles. So there were some very exciting expansions and cross collaboration that we hadn't historically seen. And I would say both within the care team and health centers, and even some across that division that Dr. Myers just spoke about, meaning health centers or primary care and public health. But what we found over the last, I'd say, 4 months or so, or over the last coming months or past months, is sort of shifting back now to the traditional or the older way. So as folks gravitated more and started coming in person, then so did the care teams kind of go back to more of the silos. So did primary care and public health go back to their respective corners of the game. And so I really think we have to challenge ourselves. We know the capability exists. We know that the potential exists. And in fact, We hear more, I would say, anecdotally than any formal surveys or work that's been done. But we hear from the health centers that in those periods of time where they were actually allowed and freed up to do work outside of their traditional job role, one, it was rewarding. Certainly the overburdenedness, it was huge. I mean, the burden on staff and hours, et cetera. But the ability to expand your scope, to be able to do things outside your kind of traditional role, and to feel that you're truly having an impact. I think we need to look more closely at that, because probably less so on the provider end, but we also do a lot of work with nurses, with MAs, again, navigators, et cetera. And I think there's a huge potential for us to explore not only bandwidth and capability within teams, but frankly, resiliency and job satisfaction and experience. I think it is absolutely key to the future of our healthcare is to explore their role in the larger system, and then feeling valued and fully utilized, which in some cases they felt more of that during the pandemic, albeit additional stresses.
Yeah, good point. Crystal.
I think from the oncology side, one of the things that I appreciated in the pandemic was the multidisciplinary care that ultimately was required to figure out how to prioritize patients, how to prioritize services, and even how to address patients that were dealing with cancer and maybe were COVID negative versus the patients that were COVID positive. In Philadelphia, which is where I was practicing and where I'm based, many of our hospital systems were able to divide a COVID positive or a COVID unit versus non-COVID care. And that allowed patients to continue to get the care that they needed while focusing resources in the COVID units as appropriate. But it really required a lot of multidisciplinary care within the health systems and a lot of coordinated efforts between hospitals or disciplines that would not have always worked well together or would not have worked as closely together. And so I think that's something that we need to remember to continue as we move forward, is that coordination of care that happened between multiple disciplines and specialties and even hospital facilities was important to get us through the pandemic and allow chronic care to continue despite the focus on the acute care needs of the COVID pandemic. And I think the other thing that was important or is important is the uniformity of the message that preventive care matters and that preventive screening matters. ACS, NCCN, and a number of organizations have worked to put out public messages about returning to screening and the safety of returning to cancer care. And I think that that is really important. It's not just one organization saying it, it's a number of organizations spanning prevention through survivorship care and all of the health systems in between. And it shouldn't just be the oncology providers that are saying it's safe to return to cancer care or cancer screening. It should also be the other providers that are doing that as well. And conversely, the oncology community needs to also remind our cancer patients and survivors that they need to get back to their other cancer screenings, their other healthcare providers, and deal with their other comorbid conditions. So I think that uniformity that maybe we all have for getting the COVID vaccine is also going to be an important uniform message across disciplines for addressing preventive care, cancer screening, and addressing comorbid conditions. And getting back to your primary care physician, as an oncologist, I'm not the only one that matters in the care of a patient. It's a multidisciplinary, multiple partnership in order to get the success we need. And the only way to do that is for everyone to be telling the patient or the survivor the same message that, these other things are as important and it's safe to do. So let's figure out how to do that safely so that you are as healthy as possible.
Yeah, those are great points, Crystal. And I think the public awareness piece is really key, especially, and maybe I'll just tie in this a little bit on this, this era of misinformation that is, haunting us all, but to continue to kind of come together across disciplines, across our healthcare system to have consistent and accurate and helpful messaging to help people get all the care they need, including their prevention. Marcus, I'm interested in your thoughts on this idea of, well, not the idea, it's an issue that we all kind of know between the ways that you might be thinking about how to help public health and healthcare, medical care come together consistently and for the future, and to strengthen that piece of things?
Well, I think there's two very clear ways that we could come together. One of them is around data systems, and actually cancer control is probably not a good example. We have excellent data systems in cancer control, particularly with the National Program of Cancer Registry. So that's a strength. The other is really around this issue of communication and outreach, and particularly communication and outreach to disparate communities. And I think there's a golden opportunity for public health really to make some changes in the type of workforce that we have, and try to bring in more paraprofessional, lay health advisor, community health worker type roles into public health agencies. And that will be a golden opportunity for public health and primary care, because then there's this very nice interface. And we've seen that with federally qualified health centers. I mean, they have been real trendsetters around using community health workers, and to some extent engaging some of the public health roles into that. But there are resources being invested into public health now. So this isn't just a pie in the sky. I think there's a real opportunity to have much better data systems, but also to really expand the workforce. But we don't need to necessarily be hiring all of the same kinds of people we've in the past. We need to be looking at different kinds of roles, and roles that can interface better. I mean, probably every one of us on this call has longstanding interest in this intersection between primary care and public health, but it's been very hard to make that happen in a really compelling way. And I think maybe the opportunity is now in front of us that we may be able to make some more inroads with that.
Yeah, couldn't agree more. And I think, maybe there is trying to see the positives that come out of such a challenge as this pandemic, but it really has, I think, for once and for all, hopefully, exposed in new ways to a broader audience, maybe, these needs and the ways that we really can do better together. And not just because that sounds nice, but because there really are strengths within so many parts of the health care landscape, I'll say, and how we bring all the pieces together to really help the whole population. Let's pivot a little bit and think about, we started to talk through this a little, I think you did, Crystal, as we think about, we'll say COVID recovery, meaning, I know obviously we're still sort of in this pandemic phase, and with the recent surges, maybe we're seeing the downswing of that, hopefully. But this recovery part of after the pandemic, I think we would all agree is going to be longer than maybe we thought. And this issue of helping the nation recover and helping people get back to their usual care or get usual care and in the first place, and to really take advantage of all of the prevention that we have, to include cancer screening and other and early detection. Let's just talk a little bit about that. Maybe there's a piece of communications on this. I think that's really key, Marcus, like you're saying, that this public awareness piece and how we come together on that. But I'd really be interested, as we kind of get to the end of this part of the panel, just some actionable steps that you all might be thinking about to each piece of the healthcare system could do to help really advance and strengthen this recovery phase.
Well, I'll lead off with one thing that I think we could all do, and this is a little bit of a more specific, but, we have a little bit, and we will more talk about disparities in this conversation because it's so important to cancer care. And we have some real opportunities coming out of COVID, but the number one thing that we need to do is fix this situation where we don't know the race and ethnicity of the people who are using our systems or suffering from various diseases. And that is a shared responsibility between public health, medical care, primary care. But, if I told you that I had no idea what the gender breakdown was of various data sets, people would be shocked. But for some reason, we accept the fact that COVID vaccination, we only know for about 50% of the vaccinatees what their race and ethnicity was. I mean, how we can say that we're serious about addressing health disparities when we're not serious about getting the data systems and the measurement right, I don't understand. And I don't think, I think it's a fixable problem. We just need to come forward with a strong determination that we are now finally going to take care of that. But we're going to have to work together on that. I mean, it goes across all the people, all the organizations on this phone and in the audience right now.
Yeah, solid recommendation. Data is the data and the disparities and demographic information so that we can actually fully understand the impact is really important. Other thoughts on how we strengthen this recovery part?
So I'll chime in a little bit about the importance of both provider and patient understanding and knowledge of what the guidelines are and what the recommendations are. So, I come from a guidelines organization, and I believe that clinical practice guidelines are helpful in setting standards for what should be done. And I think that it's not just important for the providers to know that, but I think it's important for the general public and the patients to know what the recommendations are for screening and why those recommendations are in place. So if you don't understand why you need a mammogram or why you need a colonoscopy or who should get a colonoscopy or a mammogram, you're not going to go for it when your doctor just sort of hurriedly says you should get a mammogram and writes a prescription. So there needs to be, I think, broader understanding and education. And some of that has been done really well with the clinical practice guideline organizations in terms of patient-facing versions of these guidelines, but that may need to be more widely disseminated, and it may behoove all of the providers of a patient for care to really talk about that. Again, uniform messaging out the importance of why these guidelines exist, why these screening tests are important, and what the outcomes are when you get them. That doing colon cancer screening saves lives. Getting mammograms saves lives. So I think that's really important, that knowing the guidelines and being able to talk about them in a uniform fashion with your patient, regardless of where you come from in the medical sector or the community for that matter.
Yeah, really important point. The importance of guidelines and the education piece of it. And I'm going to turn to David because I know that resonates with him.
Thank you, Laura. And I have so many swirling thoughts, and I hope the audience does too, because I agree. And I want to go with Marcus and say, the problem you're talking about is the one that keeps me up at night. I think it is important. I think we have to recognize, though, that it is the patient and people who get to decide what they are, and how to make people feel safe and trust the healthcare system, how to make a more trustworthy government and healthcare system, that people will believe that when we ask for this information, we're going to use it to improve care and not use it to target people. And this issue of building trust with our communities is really something I think the COVID has just ripped the Band-Aid off of, the distrust of the healthcare system. And so as we move forward in recovery, how do we build a more patient-centered system? I think somebody on the call or in the chat has been talking about telehealth. I think that's one of the methodologies. I'm thrilled that both Cheryl and Marcus have talked about the value of community health workers in helping us do that and understanding communities. And I think in the recovery effort, part of our issue has got to be, we can't just think one way of doing mammograms or one way of doing colon cancer screening works for a community, because that builds brittleness. And we have to be thinking about more resilient systems that have more modes. And that does two things. One, it meets people where they are. The person who doesn't want a colonoscopy, but is willing to get a blood test or is willing to get a fecal, look at their poop. There's some people who won't look at their poop, but they'll go, like, you need more than one way. And what that will do, same thing for breast cancer screening, for cervical cancer screening, the more ways we have, then when the system is challenged, we're going to be able to pivot better. So I'd love us to think about resilience, how, I'll leave it at that. Build a resilient system that meets people where they are would be a great way to help the recovery.
Yeah, I love that, David. And
let me break in here real quick. I just want to, in the few minutes we have remaining with this wonderful panel here, was there anything else in the poll, any of those other challenges that you would want anyone to comment on? And we'll also
let's go back to the poll. Oh, there it is.
Just got
I think we touched on a few of these things. We did touch a little bit on the bottom one about the value-based model, the importance of having the right incentives. We didn't yet really get to the preparedness plans of how to address cancer and other chronic diseases through times of crisis. So I don't think we got to that yet. Although we talked about ways to meet people where they are, regardless of crisis, other crises going on. And then the funding, staffing, and structural deficits, I think we've touched on in a few different ways. I was curious, just to maybe in closing, before I'm supposed to summarize this in a few minutes, Cheryl, from the community health center perspective, there's so much coming at the health centers, and it's, obviously that's, the backbone in so many ways of our primary care system, and has risen to the occasion over and over and over again as we've, as a nation, asked them to do that. And I don't think the pandemic's any different. But as we think about the role of community health centers, especially in helping communities with the resilience and this trust issue, I just see that the health centers have such a key and important role to play, and obviously are doing this already. But your ideas on actionable steps to help support the health centers even more in what they're doing, what do you think about that?
Yeah, so I would name 3 or 4 things. So one is, again, meeting patients where they are. I think that's been said again and again. And that means, in many cases in this new era, going out into their homes or doing the telehealth kinds of visits. And then couple that with the approach I talked about earlier, which is this whole person approach. And so it's coming out into the community, it's meeting a patient and their family, honestly, where they are. And then when you're talking about, if we at the National Association of Community Health Centers, our approach to cancer screening is always through the lens of a systems approach and a whole person approach. And so when we're developing initiatives to go out in and talk with patients about colorectal cancer screening, cervical cancer, breast cancer, we are wrapping that in a whole person approach. And so that would be my recommendation, which is use trusted entities like community health center care teams, build stronger partnerships in the community. And then when you go into patients' homes and you have that trust, start with talking about, do you have enough nutrition? Do you have the right kind of nutrition? Do you have access to a safe community? So you start with that wraparound kind of discussion, and how is your hypertension? How is your diabetes? And it's only then through that trusted conversation, then it's, oh, and did you know we need to be looking at cancer screening, et cetera. And so that would be, I think, our overarching recommendation for kind of the healthcare, the primary healthcare world, which is continue to build those linkages, public and primary care, build the external, but certainly as we're talking about cancer screening, to really embed that with a whole person approach, and use trusted relationships to have those conversations.
Yeah, that's great. Thanks, Cheryl. Ryan, is it my time to summarize this?
Yeah, and I'm not sure you can summarize such a robust conversation, but what jumped out at you? What were a few key themes that you heard?
Yeah, agreed. Definitely robust conversation. But I took a few notes to try to pull out some themes. I heard a few things, and this was interesting the way that this came up in different topic areas, but I definitely heard this sort of person-centered approach, I'll say. And I use, we use the word patient-centered sometimes too, but let's say person-centered, because there's definitely a huge part of the population that's not yet engaged in care in different ways. So I heard that as a big part of how we think about the recovery, how we think about helping educate through different communication channels and helping people understand the importance of cancer screening, as well as continuing their cancer care, whether they're in active treatment or in survivorship part of their lives, that this is such a key piece. And then I also heard this important part of partnerships to include addressing data deficiencies and challenges, that we need to all come together on that. And that as we do that, we can better understand the issues at hand, as well as fully represent the people that we're trying to help.
Bravo.
How'd I do, Ryan? Pretty good.
Wonderful. And thank you, Laura. Thank you, David, Crystal, Cheryl, and Marcus. It's amazing to have access to such experts. And speaking of which, we're going to turn to another group of experts, and I see Marcy popping up on screen. So our second panel is focused on some case studies of interventions during the pandemic. And I'm going to quickly turn it over to Marcy Fisher-Bourne, who's the Managing Director of Interventions and Implementation at the American Cancer Society. And Marcy, please feel free to introduce our second group of panelists.
Thank you, Ryan. Thanks, everyone. Really honored to introduce our panel, who is going to come to take those juicy questions that we just heard and talk about how they look like tangible opportunities at moving screening, at moving outcomes, at thinking about what it means to be person-centered in real life as we move through the pandemic. So we're going to start with Casey Eastman. And Casey, I'm just going to ask you to come out so we see you on video. Go on and come on video. We're going to have Casey Eastman, who is the section manager from Community Healthcare Improvement and Linkage Section in the Office of Family and Community Health Improvement. That's a really long intro to there with the Washington State Department of Health. So Casey is going to give us a picture from the Department of Health. Really glad to have you here, Casey. And next we're going to have Michael Anderson. Michael Anderson, if you could please come off. Michael is the Division Vice President for Quality and Population Health at Virginia Mason Franciscan Health. So Michael, welcome to you. Really glad to have a hospital perspective as part of this panel. And finally, Rhonda Johnson. Rhonda is the program manager of the Mammo Van with the Nevada Health Center. So we heard Cheryl talk about meeting people where they are at. Really amazing space to hear from and how that work has been going over the course of the pandemic. So let's start with each of you. And I think we'll start with Casey. So we'll go Casey, Michael, Rhonda in terms of order. If you could just give us 2 minutes briefly, sort of situate yourself, tell us about your work, how it's been going, specifically around screening and navigation to cancer care during the pandemic. So Casey, we'll start with you.
Thanks, Marcy. Happy to be here. Thanks for having us. So in Washington State, in our section, we have the federal breast and cervical program as well as the colorectal control program. And we've been lucky to have really strong partnerships in that work for many, many years. We implement the screening program through 6 regional contractors. 3 are local health departments, 2 are hospitals, and 1 is a community-based nonprofit. And they're really rooted in their communities. They understand their local partners, and between them, they contract with over 700 providers across our state. And that model served us actually fairly well in COVID, and I'll talk a bit about that. And then we also support a selection of community health centers, federally qualified health centers in our state on implementing evidence-based interventions. So we work closely with their quality teams and talk about workflows and process improvements. And that also helped us through the pandemic, or as we're still in it, but initially. And I think you'll all remember that the first case came to Washington, and we had identified that in January of 2020. So we really started first. We started from an unknown. Though we have robust preparedness plans in our state and in our state health department, the cancer program does not have one. And so we really had to prioritize where we were going to pivot and what we were going to work on, because as the earlier panel spoke to, a lot of the staff that supported our clients were pulled to response. We have a very small team at the Department of Health, just a few folks, and there were many times over the course of the first year of the pandemic that we had 1 person left to do the work of the cancer program, and the rest were responding to COVID. So I think what worked really well for us was the strong partnerships, and we prioritized supporting the clients into cancer treatment and care first. Folks that were in treatment, making sure that as systems of support like volunteer transportation to their treatment dropped out, that we were able to help them address that loss of that support that helps them stay in cancer care. And then we prioritized following up with our abnormals, folks who had an abnormal test and needed diagnostic services, trying to get them in as much as space was still open for them to get in. And I think one of the things that we do well, and it's really important for the screening programs to do and providers to know, is who our abnormals are and to be tracking them. Because when some things in some regions close down, we had that list of, as soon as they open up, this is who we need to prioritize. They have an abnormal. And then from there, screening, as much as screening was open. And we sort of saw the pandemic come into our state in different spaces and different times. So we saw mobile mammography close down in one region before another. So in some spaces, we were able to continue screening a bit longer, but in other spaces, we were not. So I think what worked well for us is that we have a really strong system of partnership, that we have regional partners that allowed us to flex as the pandemic was different in different regions. And I think that that bodes well for other emergencies too, like wildfires, earthquakes, things like that. And then we really worked with our community health centers. We have a tight-knit group that talks about their quality improvement. And as some were making workflow changes to address social distancing in the clinic or address having people wait in their cars, we shared that out to our collaborative. so that they could learn from each other. And that same sort of communication existed when they were talking about vaccine planning. So I think just having good partnerships with your community health clinics, with your regional providers, and communicating regularly was really important. And being quick to prioritize, quick to make sure that we didn't lose support for those people in treatment. We were lucky to have a foundational donor that gave some money, and we were able to call every person who was on our roster of being in treatment and offer them funds to support them through this challenging time, be it for transportation or rent, whatever was keeping them from staying in treatment. So it was a opportunity to connect to our partners and to call on our partners to help us. And then I think the other thing that works really well is that we just have a really passionate group of people. And I think folks have talked about the workforce challenge, and we have a public health system that's been responding since January of 2020. It's an under-resourced system. It is an exhausted system, but there are people and there are staff that are doing amazing things every day. And that has been essential to our success. We did see our screening numbers dip. You see them dip in March of 2020, then they go lower in April. And then by late summer, early fall of 2020, like Lisa mentioned in the chat, our screening numbers were returning. Still obviously a backlog to make up from, but our screening numbers were returning by late summer, early fall of 2020, which was really great to see. So I would say for us, we implement our program regionally, and our successes have been focused on the regional partnerships and just knowing the systems and the folks that we work with.
Casey, thanks. We're going to come back to some of these points, and I don't know if you did it on purpose, but you described planning, prioritization, people, partnerships, and passion. I was like, that's a lot of P's right there. Those are the things you just described. I know we're going to come back to them. Thanks. Michael, can we hear just 2 minutes from you in terms of overview of where this work has been for you, where your challenges have been, where your successes have been?
Thank you, Marcy. Really excited to be here with everyone today. Primarily, our work has been the success of our work has been focused around colorectal cancer screening. And we've been partnered with the American Cancer Society, and we wanted to improve colorectal cancer screening rates in our population, focusing on population targeting, shared decision making, and improving our system throughput. And we really wanted to break them out into key primary drivers. What is the knowledge and education that's needed? Where are the failures in our infrastructure? How can we influence both our patients and our care teams? And then where is the variation in our system? And when we first started this journey, our variation was hard to target because the denominator was so large, it was overwhelming. We had over 45,000 attributed patients that needed to be screened. And as we move forward in our project, we've been working on for the last 2 to 3 years, we've continued to see continuous improvement month over month. And then when the pandemic hit, very similar to what Casey described, we plateaued. So we wanted to kind of retool and come out with a new PDSA, and we came with prioritizing the wellness visit. This was a visit where we could focus on vulnerable populations in a care setting of their choosing to establish future healthcare plans whenever they were ready to utilize healthcare services. Since that time, we've seen a 37% improvement in wellness visits and seen about a 10% improvement in colorectal cancer screening. So we're now up to 71.5%. When we started this journey about 2.5 years ago, our colorectal cancer screening rates were at 45.7. So
that is super impressive. So you started this work 2.5 years ago.
Yes.
We're going to come back to just planting the seed, how the work has changed, you know, what where you were with well visits, how that changed during COVID. So we'll come back to that. Rhonda, can you tell us a little bit about your work with Nevada Health Centers?
Yes, again, Rhonda Johnson. I am with the Mammo Van with Nevada Health Centers. We are a mobile breast cancer screening unit that travels the entire state of Nevada. I kind of came in at a unique time because I came to be the manager over the Mammo Van right in the middle of the pandemic. So I wasn't with the van at the very beginning, but I did get some history on kind of what happened with the Mammo Van right when COVID hit. One of the things was they did close the Mammo Van down, as Casey was speaking about mobile units closing down. It was closed for about 6 weeks. The point behind that was Nevada Health Centers was trying to increase PPE. They were also trying to keep cases of COVID out of the actual brick and mortar centers. So that was one reason. When the heads of Nevada Health Centers came together, they said, no, we've got to get the van back on the road. Early detection is still important. We had a very passionate manager prior to me as well that was really fighting to get it back on the road, as many women require. I mean, they just rely heavily on our memo unit to be able to do their screenings. So we had to get it back on. With that, we were closed down for about 6 weeks period. So you're looking at about 60 to 100 women per week. So pretty close to 600 women that could have gone without a screening during that time. So that's a big number. We did see a drop in screenings of about 11% just for the mammo van itself. That's not for Nevada Health Centers as a whole, because not all of our patients come to the mammo van for their screenings. And so when I came on, the job was to say, how do we get people back out screening? And what are the reasons that they're not doing it? Obviously, COVID, the fear of doing that. They may have been confused about what was open or what was available. So we thought building our public profile was number one, that we educated everybody that the mammo van is on the road and that we are still working, we're still operating, we're here. We started doing that through social media as well as television. And we also were given a crucial catch grant through American Cancer Society, which kind of was a catalyst for us as far as funding to be able to take off and start doing this. And that has helped. Our goal in that grant was to increase our encounters by 11%. We have exceeded that tremendously. We are back to normal screenings for us on the mammo van. Starting probably January of this year, we have been pretty much hitting our quotas every month with a few exceptions. So we're back and doing good. I think our biggest challenge right now is funding. We do run, we help a huge uninsured population. So we do require, or we depend on the money of donors. And I think they're probably trying to recover from the pandemic themselves. So maybe those funds are just not as easily to give away right now. So that's probably our biggest challenge right now.
It's amazing that y'all are fully operational back to the numbers you were at before the pandemic. That's wonderful. Yes. Okay, so first thing I'm going to ask, and Casey and Michael, if you want to come off video, you heard some really incredible questions and ideas in the first panel. Wanted just to hear any sort of top of mind reactions, reflections on some of the questions and observations that were raised in the first panel. And I'll just let's see, Casey, we'll start with you, and then we'll go Michael, Rhonda. We'll keep the order.
Yeah, I think David brought it up first, and others echoed it, Cheryl as well, who got pulled to respond to the pandemic and the learning from that. I think we really need to take that to heart. CHWs, patient navigators, case managers are so important to our clients as they work through the barriers of getting screened, getting their diagnostics, and getting their treatment. Like Rhonda mentioned, we also serve an uninsured and underinsured population, and they really need that support. And so when there's the challenge of the pandemic and the barriers that puts on top of everything that already exists, and their support gets pulled to respond to the pandemic, that creates an added challenge. And I think that part of that is the reality of our workforce challenges, which is also mentioned in the last panel. We need to increase our workforce, and we need to have a robust workforce with an emphasis on CHWs and patient navigators that was mentioned throughout the previous panel. So,
okay, so you alluded to this.
I think that oh, go ahead.
I was just going to ask you sort of in your opening statement said, we're still clearly in the pandemic. So my question to you in that response around sort of having the workforce, around people getting pulled off, where is that now for y'all?
Yeah, we've definitely brought on a lot of staff at the Department of Health to help with our capacity. Emergency operations is run more now for the pandemic by an actual full-time staff because we had to surge our staff. But we are also doing some planning right now if we have to surge it even further, prioritizing who would we pull from various programs to support an additional response, additional case and contract tracing. But there are contracts in place and plans in place to meet a surge need. Our cancer screening partners are doing well. Obviously, the community clinics, that ebbs and flows with challenges that come up for them. But in terms of the Department of Health, we have added staff, quite a bit of staff to help us through COVID.
Thanks, Casey. Michael, what about you in terms of questions that felt maybe the most salient or points that felt most salient for you in your work?
As alluded to, relationships are key, not only relationships with our patients, but also relationships with our providers and care teams. And it has to be physician-led and physician-driven. So you have to have engagement in your clinics with your providers. And if you have that engagement, then each of the workflows and the infrastructures are going to buy in. And one thing that we've always established as the key to our successes is we always count our successes in years of life saved. So over the past year, we've added 112 years of life to the patients that we serve. And we keep that front and center. And you heard a lot about analytics as well. And we truly believe that those successes come from good analytics based on good internal data. And on every analytic that we produce, it says how many years of life that we've saved in the past 12 months. So always front and center, the why and the purposes of what we're trying to achieve. With our patients, primers and visual awareness or indicators are key. We have multiple touch points before the visit. We start with their birthday. Every month, every birthday, they get a postcard with their health maintenance reminders. We do pushes based on if their wellness visits are done. We contact them, whether it's USPS or MyChart. And really just try to engage the patient. And then when they're in their waiting rooms, there's more visual indicators. So for instance, we have 4x5 posters of why the importance to get colorectal cancer screening is done. And in every single room exam across our primary care, we have shared decision-making cards so they can choose the screen that works best for them. And we truly believe in the best screen is the screen that gets done. All of that compiled and having the patient ready with all of those key primers, I think has really helped drive success for them actually completing their screening.
That's great. Thanks, Michael. Rhonda, curious if any of the commentary or questions raised in the first panel were resonated for your work.
I did. One of the things we're also seeing from the Mammo Van is that we're out there and we're doing the screenings, but we're having a very hard time. We have caseworkers that deal with all of our BI-RADS zeros. They follow them all the way to the point of having a biopsy done and establishing if they are at a stage of cancer. And we do a lot of work, but I'll tell you, they struggle with the communication, the partnerships with other imaging centers that do diagnostic testing, as well as even just providers taking over and managing that patient's case. Because as our patients come on, they do list their PCP for us, and all that information on their testing is sent to them. But sometimes the follow-up is very lacking, and it leaves it on our caseworkers to actually do the management for them. Whereas we're trying to give it back to the physician that built the trust with that patient in the first place. So we do struggle with that as well.
I'm curious, Michael, if we could talk a little bit about your CRC project and the transitions, if there were transitions in any of your interventions during COVID. And I'll ask a little bit more, it's slightly selfish. Rhonda mentioned being part of the Crucial Catch project. My team helps manage that project, and the overall cohort of about 30 FQHCs, half of them maintain CRC screening. And as the pandemic started, through the pandemic, they were maintaining it, and that was through home-based stool sampling testing. So I'm curious, there have been questions in the chat around telehealth. In the space beyond a mobile van, were there changes that you made in terms of how you were talking about testing, where you were talking about it, who was leading that? Can you give us a picture of that?
Yeah, we focused primarily on outreach and how we were going to outreach our patients, and then targeting that outreach through the wellness visit and outreaching to our patients, letting them know that we care for them, we're there for them during this time, and that we still want to work with them to establish those healthcare plans for them for whenever they feel comfortable. And having that right visit in that right format, so they could choose to do it on the phone, they could choose to do it virtually, or they could come into the office still. That allowed us to continue to connect with those patients and really start to have those key conversations on the why they need to have this done. If they weren't comfortable getting their colonoscopy, we could mail a fit DNA directly to their house. USPS would pick it up directly off of their front porch. So understanding that they had those type of options really made an impact. And then for those patients that do come into the clinic, outreach can be very labor intensive, calling people, sending my chart messages, et cetera. So when patients are coming in for a focus visit or you know, we will actually look and do forecasting on a daily basis to see what those preventative care maintenance gaps are and then schedule them right there. So either bring them back for an annual wellness visit or a wellness visit of their payer type, or if they're they had a care gap for say colorectal cancer screening, we have established direct scheduling lines. So while we have them on the phone or in the office with us, we'll call the GI team right there and get that appointment scheduled. So we try to remove those barriers of kind of losing them after they've completed their visit.
That's great. And it's great you have the infrastructure for that. That's really amazing. Casey, this question is for you. To start with you, though, if others have comments. You talked about a really systematic prioritization at the beginning of COVID. Okay, so we're going to start with abnormals and we're going to do this. How has the prioritization process evolved and where is it now? Do you feel like, oh, we're sort of fully back? What have been sort of the variables that have been top of mind in terms of prioritization for you now?
Yeah, it's a great question. I think it's one that evolves as you look at case counts in different communities ebb and flow throughout the pandemic. But initially it was sort of a house is on fire type approach, and what if not addressed would be the most immediate issue. And so supporting those treatment clients and then the diagnostic clients were first, and that's how we came about that. But really, actually, I would say by summer of 2020, you know, and Rhonda spoke to how long their mammo van was down. I think you said 6 weeks. Folks were getting back into screening, and we went back to our normal prioritization of our program, which is making sure that we are getting folks screened and we're following up on the diagnostics, and less about supporting people through the treatment process, because that's sort of where the screening program typically stops. So I would say we've gone back to normal in terms of our prioritization, but it is really important, and we hear this when we talk with our other grantee partners, that we know our abnormals, that we're tracking our abnormals, that we have good data on our abnormals, and that we're giving them the support to get right in there. And I think to Michael's point about the system of how they have that conversation with the patient and make sure that they're aware of the process, that's really important. And we saw with our FUHC partners that we're able to maintain the improvements that they saw in colon cancer screening, breast and cervical cancer screening. They were the ones with really strong physician champions and support staff that led the work, and then quality EMR and population health tools to help them keep that list of prioritization of who needs to be followed up on after an abnormal. So that's, you know, I think we've gone back to our prioritization process before, but it really re-underscored the importance of tracking abnormals.
Great, thanks. One of the things that was raised in the first panel involves sort of the acute awareness, the Band-Aid that has been pulled off around health equity, and an increasing awareness of disparities in who comes in for care and their sort of trajectory through care. So can you speak a little bit, and maybe Rhonda, we'll start with you, about how COVID has exacerbated some of the disparities, what you've seen, aside from the 6 weeks that you were closed, what you've seen in terms of disparities and how that's being addressed, maybe even beyond the van, how it's being addressed within your clinic.
I know for our van, the Black population is very low. We only have about a 7% screening for the Black population on our van, which is very surprising to me coming in as a new manager, being that we are in those areas and we are available, the access is there. So that was one of the questions that got raised. It was also raised when I was on a meeting, a breast cancer collaboration with Nevada Cancer Coalition. This also came up about low screening rates for the Black community. So we started to look at that as I looked at our numbers, and I hate to, you know, go back into all the dividing things out based on race, but we do have a very high population of the Hispanics, as well as whites are pretty even. And then we have the Black population, which is very low. And then they bring out the information that within the Black community, the late stage diagnosis for breast cancer is very prevalent in the Black community. So we started to look at that just from the mammo van's perspective of what can we do to help facilitate this. We're in the process of setting up, we're working with some minority groups here within the Las Vegas Valley to start having roundtable discussions with the population, just to get feedback One of the things I've done is stand outside our van and actually talk to people as they come off. Number one, what's your experience with our van? Number two, what is your idea? Why are Black people not, or Black women not responding? And there's just a fear in healthcare overall, or they have a distrust in healthcare overall. So now we're kind of back to level one, where it's like, how do we, as the mammo van, what do we do to help facilitate that? So it's kind of just a hard area for us as a mobile unit to hit on, because I feel like we're there for them, and we're in the community. How do we build the trust?
And Lisa's pointing out in chat that it's so critical. That came up in the first panel too. It is a critical task and an ongoing one. Michael, what about you in terms of how you've seen disparities exacerbated during the pandemic? Oh, you're on mute, Michael.
At least once.
No, it has to happen like once during a call.
You know, we continue to study the variation that we see in our data, and it's starting to become much more clearer over the past year as we've increased our screening rates in general across the population that we serve, but really starting to show up in our Black populations, as well as our Native Hawaiian and Pacific Islander populations. And as we look at our visit rates and those that have actually accessed care in the past year, much more, we've had a sharp decline in Medicaid visits in general. So focusing on how we're going to outreach those patients and reactivate them to where they're coming back to care in a primary care setting, so we can, work on those preventative health care plans, is going to be something that we're going to have to prioritize and really figure out what those key access points are. There's many things that kind of stand in the way of that, but that's kind of the charge in front of us.
Thanks, Michael. Casey?
Yeah, I mean, I think Michael and I, being from the same state, we're seeing similar things in terms of disparities. And so just really sharing thoughts on addressing that, and how our Secretary of Health, Dr. Shah, always says we need to build back better after the pandemic. And two of his points on that, building back better, really resonate with me in terms of cancer care and disparities. And one of those is focusing on diversity and equity in our workforce and ensuring that our workforce represents the community that it's serving. And I think that gets at some of the trust concerns and understanding the challenges that the community faces. And then the other is just expanding the public health workforce, as we've already talked about, making sure that that workforce has paraprofessionals like community health workers in it. I think will really help move us on this equity conversation.
That is such a good phrase. And I'm thinking, Ryan, maybe it's the one to end on, is that we need to build back better. Do you want, is this, you're going to ask me some question here?
Marcy, we're going to ask you the same question that we asked Laura. Is a little multitasking here, but what jumped out at you? What really resonates with you as you're listening to this dialogue? And while you're thinking about that, just let me extend a big thank you to Rhonda, Michael, and Casey, not just for sharing today, but for this great work that you're out there doing. So Marcy, anything that resonated with you, and then we'll turn to Caleb to close.
Well, David Myers in the opening panel said, how do we build the patient-centered system? How do we do that? And, Casey's last point around building it better, I think, is an extension of that. How do we build whole systems for whole people? I love the idea that those people have to be at the table, and we have to, if they're not at the table, then we have to be at the street that they're at. So that's what Rhonda is doing, right? That we have to be there. And I feel like a flavor that just needs to be called out, we didn't ask a question about sort of explicitly, is around data. So Michael talked about an amazing data infrastructure. Casey managed this as well. Rhonda, you started with very specific numbers and goals and targets, and as not sexy as that may sound, this is a critical starting place that has to be throughout our work. So I was delighted to hear that while we think about whole people, that we're creating whole systems and structures that can really serve them well. All right, Ryan.
Marcy, thank you. Again, Rhonda, Michael, Casey, thank you. We're going to turn back to Caleb for a quick close.
Yeah, so thank you. Don't leave yet. I know we've tried to keep you for 90 minutes, and I have something really exciting to share with you. We have an evaluation for this session, and we want to hear from you, and we want to get that feedback. So it's going into the chat now, and I would really appreciate if you can kind of give us your thoughts, what you liked about today, what else you might like us to cover in the future, and how this is all just kind of resonating and how we can continue these conversations. So while you start opening up that link, I'll also just pile on the thank yous. Thank you to all the participants. We always know we kind of push the boundaries with these 90-minute sessions. We appreciate you staying on with us for the full 90, and we hope this conversation is valuable as the work that you're all doing. Thank you to the excellent panels. I thought both panels hit the mark and were very interesting conversations. And it's so nice to hear so many different perspectives and voices. Also, thanks to Marcy and Laura, our discussion leads. That is not an easy job. And to summarize on the spot that we do for you, I really do appreciate your guys' time and being able to do that for us. And then also thanks to the team, Ryan, Kirsten, Ryan for facilitating, Kirsten, who's going to be helping synthesize some of this information, Nikki, our Zoom producer, Megan, who's helped put so much of this content together, and Sarah, who's kind of been our content director too, supervisor for this. So really do appreciate all the team that helps put this particular production on, and we can't appreciate that anymore. So just reminders, slides and recording will be shared via email. We will have a meeting summary out for you, and it will be shared in the following weeks. That meeting summary will be shared on our newly launched Consortium website. So you can find that Consortium website at consortium.acs4ccc.org, and it has continued up-to-date information. You can also collect your email address if you want to continue to get kind of some email updates from us about other webcasts, issue hubs that we have coming down the road here. I think that is about everything that I have to share. Again, the Consortium website will be your go-to place to kind of keep up to date. Feel free to email me or the team at caleb.lavelle@cancer.org if you ever have any questions or concerns or any follow-up to this particular session. And with that, I think we'll sign off, and I hope you guys have a good rest of your day.